Well, everyone, thank you so much for coming to PACU Nursing Minutes today. I have a special guest with me, and I'm so excited to introduce you all to Jenny Finnell. She is a CRNA, and she's the founder of CRNA School Prep Academy. She's been a CRNA for 9 years, and she has had her business for the last 3 years. And she's had over 5,000 people come through her program who want to pursue CRNA. So thank you so much, Jenny. Welcome to PACU Nursing Minutes.
Thank you so much, Kathy, for having me. I'm happy to be here and happy to shed some light on those of you who are interested in pursuing CRNA.
So share with me, how did CRNA School Prep Academy become? What was your origin? How was it birthed?
Yeah, no, that's a fun question. It's funny. I know I shared with you. It was something that was not necessarily on my radar. However, I've been a preceptor ever since I became a CRNA. So I mentor students in the operating room who are actively learning the skill of anesthesia. And back in 2018, I got on social media for the first time, like ever for the most part. And I called myself Jenny CRNA. And funny enough, I was actually on social media to sell skincare products, right? But people are like, I don't want those products, but I want to know how to become a CRNA. And I'm like, oh yeah, okay, cool. Here's my cell phone. And through that, I was like, wow, there's really a need for this. So I found myself really spending a lot of time pouring into these nurses that I was mentoring. So I started a Facebook group, and that grew by word of mouth to 6,000 people in 6 months. And I was spending a lot of time, like over 20 hours a week, mentoring. I was working 40 hours a week. We had 2 little kids, and I was like, wow, I really love this, but I need to figure out a way so that I can do this more and have it be more sustainable. So in February of 2020, we launched our membership, which is CRNA School Prep Academy. And so nurses belong to this membership. It's a paid membership, but you get coaching with CRNA faculty. You have on-demand video courses, and we do live events every month. And it's just a fun way. We have community. I'm a big fan of community, and we have a private community where you can ask your questions. Faculty are in there answering them, and it creates a ripple effect, the mentorship, which is why I've become so incredibly passionate about it. It really creates kind of the pay it forward mentality where the nurses' lives that we touch, they then say, I cannot wait to be a mentor. They are so excited to just share their knowledge with others who equally want to pursue this career path. So really mentorship is where my heart's at. And yeah, that's kind of how I got into CRNA School Prep Academy and where we're going today.
Thanks. Well, that's quite a journey. It's an awesome story. Thanks for sharing that. You never know what you put out there and then what direction it's going to go and how it's going to go and how it's going to grow. And that's so exciting because right now in the nursing profession and in healthcare, just in general, we have so many people leaving and leaving and leaving.
Yes.
And we need people coming in and people like you who are passionate about helping people, move forward in their career goals. Because, my students, they may stay in PACU. A lot of them are new to nursing, and some of them definitely want to go into ICU. They want to get that experience. And when they're in ICU, they may have that itch to go and become a CRNA. And so it's one of the reasons why I wanted to have you on my show, just to share with the next generation of nurses that, nursing is so amazing because you can have so many different avenues. You don't stay in one place, you don't have to stay in the ICU. You don't have to stay in the PACU. You could go into becoming a CRNA. You could go on to being an educator for your department or into management leadership. I have peers who've gone on to become a CRNA, other peers who've gone on to the nursing schools to be associate professors, training up the next generation. My heart was always in education. And so I'm kind of staying in that lane. But I've thought about it on and off. And now, you never know what the future holds. So,
100%.
So I know for some nurses, becoming a CRNA and the whole airway, I'll just go right there to the big A.
ABC, airway breathing circulation. There you go.
That's right. And so I know for a lot of nurses, intubating is intimidating. It's scary. They have fear about not getting that airway. And so what do you say about that? If that's their fear or their barrier to moving forward?
I would first ask yourself, what is it about the airway that's so scary? And then ask yourself, what's the worst case? Like when I think of airway, the reason why I don't get scared is because ultimately, if you can't intubate, what do you need to do? You just need to ventilate. You need to exchange air. So how would you do that without actually intubating? You mask ventilate.
Yeah, BVM.
Yeah, you bag someone. And so, but that can be actually a harder skill itself than actually intubating. You know, you have people who have giant beards or, you know, no chin or sunken in cheeks, you know, and so sometimes actually masking someone is a very, is a skill set that's hard to learn, but you can, I challenge you to start trying to learn those techniques, especially as a PACU nurse. You are going to be essentially an airway expert in the sense that you're going to be holding a lot of airways. And, you know, whether you're new, whether you have plans to go on to do other types of nursing, like for example, when I went to the PACU, those nurses were very good at holding airways because they did procedural sedation. And I can't tell you how many times where like my patient was spasming or I had to go grab my syringe of socks. I'd be like, you know, I'd say, hey, Julie, get on the airway. And she would do the 2-hand mask. And, you know, and you can always, like what I do is I use my ventilator as a backup. So if I need a 2-hand mask and don't have another provider in the room, I would throw the patient on the vent and do a 2-hand mask, put an oral airway in and just do that jaw thrust, and my ventilator would do the breathing. So I don't have to actually ambu it with my hand.
Oh, okay.
But obviously in the PACU, you're going to have an ambu. It's not, but I would say use your resources. And if you need a 2-hand mask, don't be afraid to ask. So if you're struggling and you're not exchanging air and you don't see end-tidal CO2 and you don't see the chest rise, say, hey, I need a 2-hand mask. I need an oral airway. And you ask people, you delegate to get those things. You do the 2-hand mask, let someone else bag for you. And then you pink them back up, right? You bring them back up from desatting and you go in and you look. And when you pre-oxygen a patient, now if their FRC, which is a functional residual capacity, is normal, you should have approximately 3 to 5 minutes to intubate someone. That's a very long time without them desatting. Now they're not exchanging, meaning their end tidal is building, but their oxygen is going to maintain because you've built the FRC with 100% FiO2, which is your percentage of oxygen. But that being said, some of your patients are, you know, morbidly obese, or maybe they're smokers, or maybe they're frail, they're elderly. So their functional residual capacity is going to be much smaller. So your window is like, woo. So in those cases, speed is of the essence but again, you can kind of judge that based on your situation. And ultimately the biggest hindrance to intubating successfully is the prep, meaning getting them in the sniffing position, making sure that the bed is up to adequate height, making sure you have suction and suctioning a slobbery airway that has blood and secretions in it, making sure you're doing a very good, like, don't just do the gutters. You have to go down the throat and get by the vocal cords, the suction, which takes your Yankar and really getting it following the curve of the esophagus and getting back there. Because if you try to intubate and you have all these bubbles and boogers back there, it's kind of like, well, I don't know what I'm seeing. And, you know, but so I think preparation is key, and ultimately relying on your resources, using a video scope. So they have things, sorry if you hear hammering, we're doing some work on our house, like apologize. But using something like a glide scope to help you visualize the airway. They have things called McGraths. That honestly, if you ever were in a pinch, that's always a nice resource to have. A direct laryngoscopy is a skill that you do have to develop with time. There are different types of blades, whether that's a Mac blade or a Miller blade, one's straight, one's curved. You know, that takes time to learn. And, you know, if you're like, oh my gosh, am I ever gonna be able to do this? Keep in mind that when students train in anesthesia, they spend 2 years learning that skill. And usually for the first month or two, they're pretty rusty. And the biggest mistake I see new students who try to intubate is they try to rush because they're scared.
Yeah,
right? They're scared they're gonna be straight. But taking that time, getting a good sniffing position, really making sure you're getting the lips out of the way so you're not cutting lips or knocking out teeth. You kind of rock their head back gently and you go in really slow, identify your landmarks. You use your right hand to do what I call a laryngeal maneuver. And by pushing the throat back and forth, you're going to start identifying airway structures, and you'll kind of see the epiglottis pop in your view, whether that's in or out. And then you'll see the vocal cords, which look like a V. And it really, at that point, the only job you have is to keep that view. You don't look at the tube. You actually keep that view. You never look away. Use your peripheral vision to grab that tube and you stick it in. And so once you identify the airway, you never look away. You just use your peripheral vision to grab the tube and put it in, and you ask someone to pull the stylet. So I think it's just repetition and practice that makes you feel easier, like more confident with it. But really in the PACU, it's about managing the airway outside of intubation. It's about
Correct.
masking and
Yeah.
holding jaw thrust, understanding the, putting this landmark right behind your jaw.
Mm-hmm.
If you push that forward, it usually unobstructs pretty easily, and it causes pain. So it wakes them up.
A good jaw thrust.
Yes, yes. Mm-hmm.
Yes. Well, thanks so much for really going in depth about that.
Yeah.
All right. So now another question for potential CRNA future students. What is the full-time commitment and the cost of CRNA?
Yeah, that's a great question. Now, I would say I only know of one school, and I don't know if they're actually taking applications right now. It's Frank J. Tornata. I think currently it has applications closed, but they were the only program who had a 42-month program. That being said, that was like very unique. Every other program that I know about is 36 months. That's a doctoral level degree. You spend, whether they're integrated or front-loaded type of programs, essentially means whether you do a lot of your DMP work integrated with your anesthesia coursework. And typically in an integrated program, you're entering the operating room setting is slightly earlier than a true front-loaded program. A front-loaded program essentially means that you're doing a lot of your education and your schoolwork up front, and then you do your clinicals on the back end. So researching your school and understanding the style of schools, but now that they're DMP prepared programs, anticipate the first 6 to 9 months being mostly your doctoral degree work, meaning research, writing papers, all the not so ideal fun. Most people are not excited about that. They're excited to get hands-on in the operating room, that type of thing. Yeah. But it is 36 months, and the cost, I have a free resource that I will share you the link. I have it breaks down the top most affordable CRNA schools that are under $100,000. And I think there's even several that are under $60,000, but there are also a list of under $100,000, but you can get upwards of $200,000 for your schooling. So it really
is that
just
a year or total?
Total.
Okay.
Correct. UPenn is one of the most expensive programs. I think like Duke might be expensive too. So just researching, and out-of-state tuition. So if you don't have a CRNA program in your state, to get residency out of state, you usually have to plan and anticipate that and work there for the year or two leading up to applying. But it could save you thousands of dollars in tuition by getting that residency before you actually go to school in that state. So that's something, if you are thoughtful about that process, you could plan for that. All states are different as far as how long you have to be a resident of the state to qualify for in-state tuition. So make sure you're researching that. Yeah, you're looking at anywhere from $60,000 on the low end for total tuition, all the way up to $200,000 plus for total tuition. That doesn't include things like living expenses for clinical housing. Some schools include in their tuition, some don't. Some students are on their own to find temporary housing for clinical sites that may be all over the country. So yeah, you have to kind of research that, but you're looking at a 36-month commitment with maybe working part-time to full-time for the first 6 to 9 months, and then not working after that for the rest of the program.
Okay. Do you think they could do something like a travel nurse contract, or is that full-time contract commitment not going to work with CRNA school?
Yeah, I think the options to keep work is definitely there in the beginning because of the doctoral degree work, in the 9 months leading up to your anesthesia curriculum. The problem, it's not very likely to maintain a full-time position throughout your entire schooling. The only CRNA that I know that did that, he had a stat nurse position in a hospital where he worked night shift, and so he spent a lot of time studying. He kind of had a nice position to allow that, but I can only imagine that'd be incredibly hard to even maintain, because you also are not allowed to work the night before your clinicals and things like that. So you have to be schedule wise, mostly probably weekends, right? That you're doing actual work, and then your Monday through Friday is about 50 to 60 hour commitment. So that's a lot to commit to on top of working. Yeah. So most students find that they do kind of more PRN positions. That's why also I told you a little about nurses teach nurses, but a lot of the students that are in our world mentor other nurses, and they earn income to do that, meaning they might do a mock interview session or a resume edit or essay edit, and they might earn $60, $80, and maybe they do 4 or 5 of those a month. And so it's not a full-time position, but it allows them to have a flexible little bit of extra spending cash for gas or groceries. Yeah. But that's hard. I mean, but really anything you can do to kind of create some type of flexible work is good. You don't really want to commit to full-time work.
Mhm.
Because if you don't maintain your grades, you will be
Mhm.
dismissed
Yeah,
from the program.
thanks. So now, what have you enjoyed the most about transitioning into your advanced practice role as a CRNA, from, being an ICU nurse? What has been maybe 2 or 3 takeaways or enrichments that you've enjoyed with your CRNA path?
Yeah, no, that's a great question. When I decided I want to be a CRNA, I think a lot of students in nursing school, like, oh, I want to be a CRNA. They know that they make a lot of money. They know it's a good career path. And I think that's kind of where the initial interest kind of peaks, right? But when I started digging into becoming a CRNA, one of the most important things I did was I shadowed, because, if you're going to spend hundreds of thousands of dollars in 3 years of your life, you want to make sure that you truly find this fascinating. And that's kind of how at first I was like, I'm just impressed that you could put someone to sleep, cut into them, they wake them up, they never know it. I just thought the whole process of anesthesia was really cool and really fascinating. That was
Mhm.
kind of where I started. And then when I was in nursing school, I was like, I love pathophysiology. I love pharmacology. It's hard. It's not easy for me. I struggle. Those subjects were hard, but I just liked it. Like, it was like a big puzzle, and kind of how seeing all the body parts work together and how pharmacology played into that. I thought it
Mhm.
was really fascinating. So I dove into those areas in school and really enjoyed it, which drove me to ICU nursing, because ICU
Mhm.
nursing, you get to really see the pathophysiology, the disease process, the pharmacology. And
Mhm.
obviously, because you have to be an ICU nurse prior to CRNA school, I was like, maybe this is a good fit. So I shadowed again. And when I shadowed again, I was like, okay, I'm like lit up now. I have to, this is so cool. I really want to do this. And really what kind of fascinated me was just the fact that a nurse could be at the head of the bed, being in charge and making airway judgments and pushing pharmacology, mixing it up, titrating
Mhm.
drugs, and understanding the fluid shifts of surgery and waking them up safely and bringing
Mhm.
that peace and comfort, that alleviating anxiety and fear. Like this, the CRNA, the nurse could fulfill that entire role. And I
Mhm.
thought it just seemed so rewarding. So I made it my point when I went to the ICU to put CRNA as my goal. And now that I'm a CRNA, I do agree that just that one-on-one connection you have with your patient in pre-op, being that one to smile at them, alleviate their fears, answer their questions, and,
Mhm.
and being really the last person they see before they go to sleep, the next person they see when they wake up.
Mhm.
When they wake up and they're like, have we gone back yet? And you're like, you're all done. Like, that's like the best compliment you can get as a CRNA. You're like, you don't even know
Mhm.
you had surgery.
Yes.
But it's just, it's fascinating. It's a lot of hands-on.
Mhm.
Epidurals, spinals, A lines, central lines. And epidurals could be labor epidurals. It could be thoracic epidurals.
Mhm.
I did four and a
Yeah.
half years of open heart. So you get to do that, a variety of procedurals stuff.
Yeah. So doing all of your regional anesthesia, all your blocks, what was your training for that?
Yes, blocks in school, they typically give you a rotation, your block rotation, and you go
Mhm.
to, usually it's some type of outpatient ortho center is probably the most common, where you do a lot of popliteals,
Mhm.
supraclavicular, interscalenes, maybe a saphenous block or femoral block. Did I say popliteals? I think I
Yeah.
did.
Mhm.
Adductor canals. So you get a lot of exposure. I recently did a contract at a hospital that did a lot of tap blocks. And so
Yeah.
I as a CRNA, got trained how to do tap blocks. And really, with blocks, it's about knowing the anatomy, the landmarks, and using an ultrasound. A lot of nurses now have the ultrasound IV skill. So it's similar in the fact that you hold the ultrasound, but really finding the needle when you're deep in tissue is the hardest part, and holding it steady and making real fine tweaks with the ultrasound to
Mhm.
find your needle, identifying the nerve, the artery,
Mhm.
things like that.
Mhm.
So you get about a month training where you maybe get, I don't know, I probably only had about 30 or 40 blocks, so not a lot.
Mhm.
But then as a CRNA, I didn't really get to do a lot of that in my first job. So when I moved after 4.5 years, I moved to a outpatient surgery center, and they did a
Mhm.
lot of regional. The CRNAs did all the blocks.
Mhm.
So I got trained on the spot, on the job. And after about 2 weeks of training, I was free to fly. And in a busy fourth quarter, which was the end of the year, we had a lot of people come in. I would do 30 blocks a day in an 8-hour shift. So it was
You
just
got
like,
good.
oh, it was just, rapid. It was just, the nurse would bring him back. I block, they bring him back out, next one. And
Mhm.
so you get really good or really proficient really quick when you're doing that number of blocks.
Mhm.
So I tell a lot of students, your schooling is really to get you exposure and
Mhm.
experience. But even like my epidural experience when I was in school was really kind of, I barely got my numbers to do labor epidurals.
Mhm.
Then after school, I trained for an open heart team, and I did a lot of OB because I was a 24-hour CRNA. So I got very proficient at doing epidurals because I was the main provider at night doing the epidurals. And so, yeah, schooling's exposure and enough to get you to be able to pass boards and get your license. But the majority of your training really comes for the most part after school.
Yeah, kind of like nursing school.
Yeah, exactly. Yep, true.
All right. So after a nurse decides that they want to pursue CRNA and they're in the PACU, they need to go get ICU experience. How many years of ICU do you think they need before they should consider applying for CRNA?
That's a great question. And I wish I could say there's going to be a 100% answer for all of you, but really the answer is it kind of varies and depends on the school you're applying to.
Mhm.
And some people are like, but I know a PACU nurse who got into CRNA school, and that may very, very well be true, but did they only have PACU? More than likely, they did not only have PACU. Maybe they were an ICU flight nurse for a year, and then they went to PACU and applied, and they got in that year.
Mhm.
And some schools will have a 2 to 3 year requirement for ICU experience as far as how current, meaning you have to have had your ICU experience within the last 2 to 3 years.
Okay.
But that being said, that's not preference, meaning they prefer you to be current, which is why I kind of leave that as a caveat. Like, don't take that literally. Know that they have 340 applications for 30 seats. And if out of those 340 applicants, 150 of them are current in ICU and you're not current, the ones who are current are going to probably get preferential treatment. And so being current is really always the best way to put your best foot forward. So if you're a PACU nurse with no ICU experience, I do encourage you to understand the school you're applying to and what their requirement is as far as do you need to be current or not. And know that if you apply without current experience and you don't get in, go back and get ICU experience, be current, and then reapply. But also know that some schools limit you on how many applications. Some schools will say you
Let's
can apply
talk
here
about
twice.
Yeah, go ahead and tell me because I was looking over your website and I didn't know that there was a limitation on how many times you can apply. So share that with everyone.
Yeah, that's also school dependent, which is why, when I first started embarking on trying to mentor, it's just like, oh my gosh, no wonder this is so hard. Like all the schools are similar but different, and kind of understanding the little nuances. Like if you research one school and you assume a blanket statement, all schools are the same, you're going to be in big trouble. Like you have to treat every application, every school as a unique application, unique requirements, unique needs, and what they want. Maybe they care more about leadership and volunteer activities. This one really cares that you are have above a 3.5 science GPA. That's like a big thing for them. And so understanding the nuances for your school is really key. So again, some schools will say you get 2 tries at applying to our program. And if you don't even get an interview, you can't apply again. So if you just wing your application and say, I'm just going to see what sticks, I'm like throwing spaghetti on a wall. And that's not probably the best approach all the time. Right. The other problem is some of these schools, you might apply just to see what the heck happens. And you may get ghosted when it comes to getting feedback. And the reality is they can't coach hundreds of people who apply to their program, which is also why CRNA School Prep Academy kind of stepped in. It's a need. It's a very big need for students to get feedback, but not all schools can give you the feedback because there are faculty who's teaching, who's working full-time, who's very limited and can't spend hours and hours back and forth in email and bringing people in the office hours for individual coaching. Some schools can do that. So that's why I said, don't say you don't take advantage if it's there. Meaning if a program will sit down with you and coach you through how to make your application better, oh my gosh, you hit gold. Like that's a gold mine. Do it, take it to heart. But if you do have the opposite experience where you don't get in or you don't get any feedback, know that that's a very common experience. It doesn't mean you're not worthy. It doesn't mean they don't care. It doesn't mean that it just means it's just that school. Okay. And try to be resourceful and see what else is out there to help you navigate how to improve. But yeah, research your school, figure out if they have an application limit. I really think you should take every application really seriously and try to put your best foot forward. And if that means going to be current in ICU, some schools have a 1-year requirement. Some schools have a 2-year requirement. And then some students are like, well, if I have 8 months and by the time I interview, I have a year, does that count? There's like so many like what ifs, right? Yeah. And my answer is yes and no. It just depends on the school. You can do that and give it a shot. I've had someone, one of my best friends, she's a colleague, interviewed for CRNA school with 6 months of ICU experience. She got in. Now that's not the norm. She was an outlier, but she got in. So by the time she started the program, she had a solid year.
Okay.
Because usually there's a 6 to 9 month delay before you actually start the program. So it
Mhm.
is possible, but she had to have everything else lined up to a T. She had good grades. She had leadership roles that she got very quickly as soon as she got her foot in the ICU. She worked really hard in the beginning to get trained on CVV HD. She didn't have her CCRN. You can't have your CCRN because you don't have the hours to sit for
Right.
it.
Mhm.
So you have to think about that. What else can you do to really stand out if you don't have the CCRN? And does your school require it? Because if they require it, well, then that's not an option. You have to have at least that amount of experience to sit for your CCRN.
Okay.
So as you know, like as I just exposed, it's so school specific.
Right. Exactly. Yeah. Yeah. I didn't realize that some may require your CCRN. So that's
Mm.
another important thing to know. So, and just for all of you nurses out there, don't do what I did for your CCRN, because I waited 10 years to get my CCRN. And I had been the code blue nurse, the rapid response nurse. I'd been in MICU, neuroshock trauma, CVICU, and I waited 10 years. And my husband, he had to get it for his flight, and he's like, it's
Mm.
time. And I was
Yeah.
like, yes, but I had this self-doubt of
Mm.
like, I kept doubting that I didn't have the knowledge, and I passed it with like flying colors. And I was like, wow, why did I mull over that for so long? And I wasted so much time and energy thinking that I wasn't smart enough to do that. So
Oh, yeah.
yeah, everyone, don't do what I did. Just get your experience when you feel ready, get
Mhm.
a study guide, and then
Yep.
go and do it. So
Yep. Yep. There are definitely tools to help you pass that test. And I also will
yes,
add one more thing to this is don't wing that test either. Because
no.
some schools will want to know your score.
Uh,
So if you barely pass, don't get me wrong, you pass, but when they like, what's your score? And you're like, I passed by 1 point
uh-huh,
versus a candidate who passed with an 80% or 84%, which is usually like 100, 110 is an
uh-huh.
84% on that test. Well, they're going to be like, well, the student who get an 84% probably has a better understanding of the critical care knowledge than someone who barely passed the test. So
Yeah.
take it
Yeah.
seriously.
I have a good girlfriend out here on the West Coast, Nicole Kupchik. She has an awesome
Yeah.
certification. Yeah, her and I go back like 15 years ago from
Oh, that's
when I
so
used,
cool. Love
yeah,
Nicole.
yeah, she's amazing. So
Hmm.
yeah, so what I would do is so in the show notes, I'm going to include your website, and you have a podcast with tons of resources for student nurses. So that'll be in the show notes for this. I'll even throw in Nicole's her link for anyone who is thinking about getting their CCRN. And yeah, I might just go ahead and just pop on over and share your website real quick. Are you cool with that?
Sure, sure.
All
And
right.
I can I have a 8-step guide that's free that I can give you the link for, as well as I know you mentioned cost of CRNA schools. I have a free resource for that too,
Okay.
just to kind of help people navigate, if they're really planning for CRNA. And the tuition that's listed on the free guide is that's the entire tuition. But obviously check the websites because they do update that probably
Okay.
almost yearly these days.
So this is Jenny's company's website, CRNA School Prep Academy, and there's tons of podcasts on here with great references. And you can join her academy if you're ready to go that avenue with your career. And yeah, Jenny, just thank you so much for taking your time out of your busy business and work day and family life to share with me a little bit about CRNA School Prep Academy and just how to pursue that career track if that's calling on your heart.
I appreciate the opportunity, Kathy. It's been a pleasure.
It's been a really nice pleasure chatting with you, Jenny. You have a great rest of your day.
You too. Okay, thanks, Kathy.
Okay,
Bye.
bye.